Jerry's been in rheumatology for over 50 years. He retired a few years ago. I have a long write-up on medical stuff that he's done, but the most important thing on this whole list I noticed was that he just finished building a large retaining wall for his daughter's garden, and I think that that's a skill that many of us could probably utilize. He was at Leahy in the Department of Rheumatology. He was a member of the Leahy Board of Governors for 10 years. He's on the Board of Trustees at Brookhaven and a whole bunch of other things. So let me turn this over to Jerry.
Well, hi, thank you for having me here. First of all, I thought I would start by giving you something oddball. Usually at the supper hour on television, I call it the advertising hour for oddball medicines. And they have all kinds of medications that we've never heard of up there all of the time. And one of them is this non-pronounceable Bimzels that works differently. And as you look at the advertising, it looks like they're advertising. Bimzels seems to be geared to men who don't dress up very much. And they're talking about the AF difference. I assume A is passing and F is failing. And the most important part of the ad is this IL-17A and F, whatever that means. Safety. Side effects include suicidal thoughts, serious infection, including tuberculosis, liver problems, but we don't know what it's for. But in the fine print, it says psoriasis. So do we know enough about this ad to even think about using it? Well, in this next hour, I'd like to try to look at and bring you to successfully being able to interpret this kind of an ad. Okay, I'm retired from Leahy after many years. I've been a rheumatologist doing clinical practice, research, and teaching all of this time. And when we gave medical talks, we always had to give a disclaimer. So this talk is unfortunately not being supported by any drug company. Okay, goals of the talk. We're going to review a little bit about the history of inflammation, see where the concept came from and what it means, a little bit about basic cell biology, introduce the concept of interleukins. Hopefully it's new to all of you, but who knows, and then show the relevance of inflammation today. So that's our goal for this period of time. When you have a cold or a flu, you have aches, you have pains, you have chills, you have fever. But why do you have all of these symptoms when you just have a sore throat, like a tonsillitis or a flu? Why do you have symptoms all over your body? Okay, let's look at the ads on television for a minute and see what you remember. Skyrizi is being advertised very heavily in that 5 to 7 o'clock hour. By the way, we're going to concentrate on the ads that look at inflammation, not all of them. There are many others as well. There's Skyrizi, Humira, Rinvoq. I mean, what do these words mean? What do they do? Are they meaningful to us at all? Understanding a bit about inflammation is important because all of these medicines block the inflammatory response to some extent. And that's what we need to understand. Celsus, not Celsius, but Celsus, in around 50 AD, was a Roman physician who defined the characteristics of inflammation that we still use. Rubor et tumor cum calor et dolor. That's redness and swelling with heat and pain. And about 100 years later, one of his buddies, Galen, talked about loss of function because of the rumor et tumor, calor et dolor. And you have the characteristics of inflammation that we still think about today. Here's a normal knee. This is the patella, and the patella is in a sac. Above it is the suprapatellar bursa. A bursa is an empty sac that can fill up, and it enables the patella to more easily move back and forth with motion. But when it gets inflamed, it fills up, like this one. This is the patella, and here's the suprapatellar bursa loaded with fluid. If you touch this, this is hot. And if you press it, the patient is going to say, I hurt. So you can see rubor et tumor cum calor et dolor. The gingerbread man goes to the rheumatologist. Sore knee, have you tried icing it? Well, the question is, does ice block inflammation? Ice constricts blood vessels, but it doesn't touch the mechanism of inflammation at all. So even though you might feel better with icing a wound, you will continue to have inflammation long-term until it goes away or you block it. Okay, we really need to get to some basic definitions. Inflammation is not infection. That's obvious. Infection is an invasion of the body from some outside source, but the body's response to that invasion is inflammation. So an organism, a virus, a bacteria, parasite, a fungus, can infect us, and our response to that is inflammation. But, you know, if you get a wound, a splinter, an injury, a tetanus shot, all of those things you will also respond to with inflammation. And the inflammatory system is so geared that if your body senses something it feels abnormal inside your body, even though it's not really abnormal, it will respond with inflammation. Okay, let's assume you have gout and you have the crystal of uric acid. Your body responds with inflammation, but we can't kill it. So the inflammation goes on until we metabolize the crystal. Suppose you get a tetanus shot or a COVID shot. That's a protein that's foreign, that's carried to regional lymph nodes until it's processed and disappears. We can't kill it, but we process it. How do you kill an altered DNA? Okay, let's explain that. Viruses get into our body, and sometimes a portion of a virus or a whole virus takes residence on a DNA molecule. Our body knows our own DNA and senses it as self. It belongs to us. But as soon as there's a virus living on it, it's no longer self. It's an abnormal DNA, and our body fights it with inflammation. We get sicker because of that inflammation, and to get better, we can't use an antibiotic because there's no infection. We have to treat and block our own inflammatory response. So those are the key points I want to try to make here. Okay, a pop quiz. These are rhetorical quizzes. Actually, you're all there. In Roman times, other than battle axes, chariot accidents, what was the most common cause of inflammation? Rheumatoid arthritis, tuberculosis, or gout? Anyone care to guess? Good. Rheumatoid arthritis is a new illness. It's not an old illness. If you look at skeletal remains dating back centuries, you don't find much rheumatoid arthritis until last couple hundred years. Osteoarthritis went on forever. Tuberculosis went on back for many, 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 many centuries, involved joints, and it is in skeletal remains, but not as common as gout. Gout was common because pottery had lead in it, and high lead levels increased the risk of gout. Lead poisoning leads to kidney failure and gout. So inflammation in Roman times was commonly associated with gout. How do you block that inflammation? In Roman times, there was a plant growing wildly called colchicine, and people knew that colchicine worked. So as soon as you got an episode of gout, you went outside, you got some colchicine, and you felt better. But colchicine doesn't work today for most forms of inflammation. Okay, what we really want to do is look at three breakthroughs in understanding of inflammation. We're going to look at aspirin, non-steroidal anti-inflammatory drugs, and interleukins. So let's start by looking at aspirin. Felix Hoffmann was a researcher in Germany working for the Bayer company. He went through the University of Munich and became a star pupil there. Bayer himself got to know Felix Hoffmann and hired him and brought him to the Bayer company, where Felix Hoffmann was working on a chemical called salicylic acid. Salicylic acid was used for arthritis in those days, and the problem with it is it was caustic. It helped the arthritis, but everybody who took it complained that their stomach hurt. So Bayer was trying to make the drug more palatable in some way. And there's always mythology to what goes on. The mythology with Bayer was that his father had rheumatoid arthritis. And the father said, Felix, this stuff, salicylic acid, works, but it bugs my stomach. Find something that works just as well that doesn't irritate my stomach. Okay, the other researchers of the day were working on the carboxyl group, trying to acetylate it. Felix Hoffmann didn't do that. He worked on the phenol group and started to acetylate it. And what he made by his acetylation was acetyl salicylic acid. He was the first person to make aspirin. That was his claim to fame. He actually named it. The A came from the acetyl group, and the spirin came from the genus Spirea, which are the shrubs that were growing wildly then and cultivated now that contain salicylates. So he had aspirin for his acetyl salicylic acid. This is the original bottle, excuse me, original bottle of aspirin that was used by the Bayer company to market aspirin. And it was a powder, not a tablet form. You mixed it with water, drank it down, and your arthritis got better, and it still bugged your stomach, but not as much. You acetylated the phenol group, and as soon as Felix Hoffmann did that, he told his boss, who headed the pharmacology department, and the boss said, let me try it. The boss tested it on himself before it was given into human and then animal trials and then put on the market. It was discovered in 1897 and was on the market being sold in this bottle within 3 years. Our Food and Drug Administration can't come near that time sequencing. Okay, what else did Felix Hoffmann do? He was acetylating salicylic acid. He was acetylating multiple drugs. And within 2 weeks of acetylating acetyl salicylic acid, he acetylated dihydromorphine, which was dilaudid. And when you acetylate dihydromorphine, you get diacetylmorphine, which is heroin. He was the first person to make heroin, and he did that within 2 weeks of synthesizing aspirin. Heroin worked by blocking pain dramatically, and it was heroic. This is the word in German for heroic, and the name stuck. Heroin is a heroic medication. Why do you acetylate groups? Because they're more acetylate medications, because they're more easily absorbed. You increase the serum level, and because of that, you can get across the blood-brain barrier more easily to get pain relief. So aspirin worked pretty well. Aspirin has two basic effects. It blocks inflammation and it bugs the stomach, causing a lot of stomach irritation. Okay, we now have aspirin, but how does it work? How does it block inflammation? And why does it cause pain and bleeding? In 1971, I was just starting my rheumatology fellowship program. And this is before I met John Rudy, by the way. In 1971, the way you had a rheumatology fellowship was you worked with an eminent rheumatologist. I worked with a guy named J.D.C. Gowans, who's a proper British rheumatologist here in the States. And you stayed with him, following him, talking about every patient, seeing every patient together. One of our patients, this is a prototype, came through complaining of knee pain. And the reason he came in was not only knee pain, he had a problem with the knee. And he basically said that his problem was when he went to church and knelt in church, he suddenly got knee pain and had to stand up in the middle of church, in the middle of the prayer, and was very embarrassed. And he wanted us to do something so he would not have his embarrassment. He wanted his pain to go away. Well, Gowans talked to him, told him a different way to use aspirin, shook his hand and said goodbye. And the man said, but wait a minute, you didn't tell me what to do about my embarrassing problem. And Gowans looked at the man and said, kneel in the last pew. The reason is that in 1971, we had aspirin, modified aspirins, we had narcotics, but we didn't have anything else for inflammation. All we had, if you will, was aspirin-like drugs. We had general surgery, you could fix a broken bone, but we didn't have arthroscopies, we didn't have joint replacements. We didn't have very much to offer him. But at the same time, in 1971, there was a British researcher, J.R. Vane, who in his laboratory in London, University of London, was studying peristalsis. Peristalsis is the muscular contractility of small bowel or the stomach. And when small bowel contracts, it tightens, and then it releases mucus. Whenever you irritate that small bowel, either with acid or food, or even think about eating or touch it, it contracts and it releases mucus. Well, Vane said mythologically, he didn't know why he did it, but he took a physiologic solution of aspirin, put it into the bath, and he had paralyzed the peristalsis. The intestine stopped moving completely. And he said, my eureka moment. Now I know how aspirin works. Aspirin blocks the chemical that makes the peristalsis happen. And that chemical was called prostaglandin. What he did was discover that aspirin inhibits prostaglandin synthesis by blocking the enzyme cyclooxygenase. That one discovery led to the whole family of non-cortisone, non-steroidal anti-inflammatory drugs. And it was so profound that he was knighted by the Queen a number of years later for his discovery. Okay, cyclooxygenase is an enzyme that propels the reaction more quickly. It takes arachidonic acid, which is a lipoprotein found in membranes of cells, and it makes it into a cyclic product. Arachidonic acid in the membrane is preformed, released upon almost any contact. Cyclooxygenase, by the way, there are a number of different forms of it, cyclooxygenase 1, cyclooxygenase 2, but they have the same effects on the arachidonic acid in making prostaglandins. The prostaglandins are inflammatory mediators. They do many things through the entire body. They make peristalsis happen. They make inflammation happen. There are two principal kinds of cyclooxygenase. Cyclooxygenase 1 and 2. The difference is one amino acid, isoleucine versus valine. Cyclooxygenase 1 inhibition has profound stomach intestinal toxicity, ulcer, bleeding, and this happens, now you can understand, because aspirin paralyzes the GI tract. It stops moving, it stops having its peristalsis, and also stops making mucus. It's the mucus that protects the mucosa, the lining, from aspirin and similar drugs like the non-steroidal agents. COX-2 agents, their inhibition leads to cardiac and kidney toxicity. So these drugs, while they work well, clearly have toxicity. Okay, here's the whole sequence to look at. The cell membrane has phospholipids, and one of them is arachidonic acid. With cyclooxygenase, you cycle them and you make the prostaglandins, which are mediators of inflammation and pain. Cortisone is a dramatic natural substance in our bodies, and it works by blocking the entire sequence up high. It blocks everything in the cyclooxygenase system. It blocks inflammation and pain quite dramatically, but we don't use it that much because of its side effects. Its side effects involve every organ of the body and are profound. It also blocks cyclooxygenase, but more specifically, aspirin and NSAIDs block cyclooxygenase. Aspirin blocks it non-competitively, permanently, until you remake more cyclooxygenase. NSAIDs do it competitively, and the result is you can quickly rebuild your cyclooxygenase. So the system is not as dramatic as it is with aspirin, but they both work to mediate inflammation and pain. Okay, let's talk about the NSAIDs a little bit and where they came from. Prior to 1972, we had salicylic acid, aspirin as of 1897 with Felix Hoffman, and a modification of aspirin called Indocin, which is about 17 times stronger than aspirin and 17 times more caustic on the stomach, causing ulcer and bleeding as well. And before the 70s, that's all we had. Starting in the 70s, we got 20 or 30 different non-steroidal agents over the years. You recognize Motrin, Naprosyn, probably not many of the others. The purple ones, I did some clinical research on. Vioxx caused some pretty significant cardiac toxicity and is off the market. Meclamin is a great drug, but it causes too much diarrhea. Toradol is probably the strongest pain reliever of the NSAIDs, but it also is the strongest inhibitor of gastric motility and causes a great deal of ulcer and bleeding. Now, there are two classes based
Joey, are there
upon
also kidney issues with the NSAIDs?
Toradol, Vioxx, all of these agents cause kidney toxicity. They block kidney function and cause kidney failure. So all of the NSAIDs do that. And before you take NSAIDs, if you look at the warnings, you'll find that there is a risk of kidney failure. Don't take them or take lesser dosage if you have a kidney problem. So that's true. Now, the NSAIDs fall into two classes, the COX-1, cyclooxygenase 1 inhibitors, and the cyclooxygenase 2 inhibitors. Most of them do both to some extent, and they're selective. This is a busy slide, but the more COX-1 selective have increased gastrointestinal toxicity. This is the one with diarrhea, and this is the one with severe ulcer and bleeding. The COX-2s are the ones that have more cardiac and kidney toxicity, and the ones in the middle, like Motrin, have less toxicity, but don't work quite as well. If you want to decide what the toxicity is of these drugs, just as an aside, you don't look at the internet because the internet will give you too much information that comes from the drug company itself and doesn't have the information you're looking for. Look at pdr.net, physiciansdeskreference.net, and let's look up colchicine, the treatment for gout, old-fashioned anti-inflammatory. It's on the market called Colchris, and there's an index of what colchicine does, including its adverse reactions, which are nausea, vomiting, diarrhea for the most part. But look at the space here between A and C. There's no B. If you look at other drugs, like our friend Toradol, there's a B, a boxed warning. The boxed warning are the Food and Drug Administration's warnings about major toxicity, this time because of ulcer, bleeding, and death because of it. It's still on the market in the United States. It's used restrictively, but in some countries, it's off the market because of its toxicity. Okay, so now we're back in the 70s. We have aspirin, we have non-steroidal agents, we have arthroscopies, we have MRIs, we have joint replacement. We can treat infection, but we can't really treat inflammation well enough because we don't understand it well enough. So let's take a leap of faith and look back into blood basics a little bit. The histamines are also formed immediately when you irritate the cell membrane. When you irritate the membrane and phospholipid arachidonic acid, you cycle them and get a whole variety of products. Bradykinin slows the heart tremendously. Leukotrienes are related to anaphylaxis, histamine related to allergies. If you block histamine, you block allergies. That's how cortisone creams block allergies by blocking the histamine release. Prostaglandins irritate the stomach, mediate inflammation. So you have profound effects through the entire body by blocking either with cortisone or non-steroidal agents, prostaglandin development. And histamine is one of those. You're absolutely right. Pain that we still can't block completely because we don't understand inflammation. And in blood basics, we have cells, red cells, white cells of different kinds, clotting cells, stem cells, dendritic cells, lots of cells. We have lymphocytes that we knew had something to do with the immune system, and polymorphonuclear leukocytes that had something to do with infection. So this is what blood looks like. The biconcave discs, the red blood cells that carry oxygen, clotting cells all over the place of different sizes. We have lymphocytes. Some of them are marked T and some of them marked B when you look at them biochemically. And then you have the polymorphonuclear leukocytes. The immune system at about those days was related to two different kinds of immune systems. The first kind, the innate immune system, we are born with, and the other kind we acquire. The difference is when you're born with a system, you principally respond with T cells to fight whatever the cause of inflammation is, non-specifically. The acquired system, you bring in B cells that make antibodies and work more specifically. Where do the T and the B come from? What do they mean? T cells are born in the thymus. They cycle through the body, go through the thymus, and they are indoctrinated in their life function in the thymus, and they are called thymic cells or T cells. B cells are bone marrow cells, and in the bone marrow, they learn how to make antibodies, so to speak. There's also another group of cells, non-committed, and we sometimes used to call them tolerance cells. Why tolerance cells? Some people don't get an illness and other people do. What makes one group of people get sick and another not? Why does one person develop a cancer and another one doesn't? We used to think that there were tolerance cells, and if we could find those tolerance cells and utilize them properly, we could block a whole series of illnesses. Okay, the innate immune system that we're born with is non-specific. It responds to any kind of inflammation with T cell responses, but doesn't remember what it did. So a couple months later, you get the same injury or illness, and it responds the same way. Whereas the acquired immune system works a little more slowly the first time because it is antigen specific. An antigen is a protein that stimulates the development of an antibody. And an antibody is made specifically to an antigenic stimulus. The antigen is made by the T cell bringing it to a lymph node where B cells make the antibodies. And this is an acquired system. So if you have a strep throat, you're supposed to make anti-streptococcal antibodies. We don't want you to die from stepping on a rusty nail with tetanus, so we give you a tetanus shot. You then make anti-tetanus antibodies specifically the antibodies fade out, but you remember them in a memory T cell. And the next time you step on a rusty nail with tetanus on it, the T cell stimulates B cells, and boom, you instantly have antibodies. And this is a higher vertebrate system. It's not throughout the system. Okay, we're going to put on a video now because this is the best way to look at the
Our body has a powerful army
immune
that
system.
protects it from various types of threats. These threats can come in the form of mechanical injuries, the entry of germs, or the entry of other foreign particles like dust. This personal army is called the immune system. Every day we encounter a huge number of bacteria, viruses, and other disease-causing organisms. However, we don't fall ill every other day, which is due to our immune system, an army of cells that is always roaming our body, ready to ward off any attack. The immune system can be broadly divided into two parts, innate and adaptive immunity. Innate immunity, or non-specific immunity, is the body's first natural defense to any intruder. This system doesn't care what it's killing. Its primary goal is to prevent any intruder from entering the body, and if it does enter, then the immune system neutralizes this intruder. It doesn't differentiate between one pathogen and another. The first component of this defensive system is our skin. Any organism trying to get into the body is stopped by the skin, our largest organ, which covers us. Secondly, there is the mucous lining of all our organs. The sticky, viscous fluid traps any pathogens trying to get past it. These are the two physical barriers. However, we also have chemical barriers, such as the lysozyme in the eyes or the acid in the stomach, which can kill pathogens trying to gain entry. The genitourinary tract and other places have their own normal flora or microbial community. These compete with pathogens for space and food, and therefore also act as a barrier. The next line of defense is inflammation, which is done by mast cells. These cells are constantly searching for suspicious objects in the body. When they find something, they release a signal in the form of histamine molecules. These alert the body, and blood is rushed to the problem area. This causes inflammation and also brings leukocytes, or white blood cells, which are soldiers in our body's cellular army. Once they come, all hell breaks loose. Sometimes, however, the intruder may not be a germ, but rather a harmless thing like a dust particle. The body still causes a full immune reaction to this intruder, which is how allergic reactions occur. In the fortress of our body, the leukocytes are VIPs. They have an all-access pass to the body, except, of course, to the brain and spinal cord. Our leukocytes come in many types. Those that belong to the innate system are the phagocytes. These cells can either patrol your body, like the neutrophils, or they can stay in certain places and wait for their cue. Neutrophils are the most abundant cells. They patrol the body and can therefore get to a breach site very quickly. These cellular soldiers kill the infectious cell and then die, which leads to the formation of pus. There are also the big bad wolves, or the macrophages. These cells are like hungry, ravenous monsters who simply engulf unwanted pathogens. Instead of roaming freely in our blood, they are collected in certain places. These cells can consume about 100 pathogens before they die, but they can also detect our own cells that have gone rogue, such as cancer cells, and kill them too. Beyond that, we also have the natural killer cells. These cells can efficiently detect when our own cells have gone rogue, or are infected with, say, a virus. NKCs detect a protein produced by normal cells called the major histocompatibility complex, or MHC. Basically, whenever a cell isn't normal, it stops producing this protein. The NKCs move around constantly, checking our cells for this type of deficiency, and when they find an abnormal cell, they simply bind to it, release chemicals, and destroy it. The last cells of our innate immune system are the dendritic cells. These are found in places that come in contact with the outside environment, such as the nose and lungs. They are the link between our innate and adaptive immune systems. They eat a pathogen and then carry information about it to our adaptive immune system cells. This information is produced and shared in the form of antigens. Antigens are the traces that pathogens leave behind. They are molecules found on the surface of pathogens that can be detected by our adaptive immune system for recognition. The dendritic cells pass on this information to our T cells. However, macrophages can also perform this function. Now, there is also the adaptive or acquired immune system. This system is more efficient as it can differentiate between different types of pathogens. It has two main components, T lymphocytes and B lymphocytes. T cells come into play when an infection has already occurred, thus bringing about the cell-mediated immune response. B cells join the fight when the pathogens have entered, but haven't yet caused any disease. This is called the humoral immune response. Some T cells take signals from the dendritic cells or macrophages and are thus called helper T cells. They perform two key tasks, forming effector T cells, which are basically cells that cycle through the body and call in the cavalry, namely other white blood cells. Helper T cells also form memory T cells, which keep a record of this antigen for future reference. Sometimes, some cells of our body know that they have lost the battle. They have become heavily infected with pathogens, so there is no hope left for them. At this point, the immune system brings out the cytotoxic T cells. These cells rush over and perform a mercy killing for the infected and dying cell. Furthermore, we have the B cells. They produce chemicals called antibodies, which fit on the antigens of pathogens, much like how a lock and key fit together. These antibodies crowd around a pathogen and act like tags. They signal the macrophages to come and kill the marked pathogen. B cells also produce memory B cells when they encounter an antigen. The B and T memory cells jointly maintain a record of all encountered infections, and thus strengthen and solidify the body's immune response to these infections in the future. Our innate response is quicker, though non-specific. It gets into action within hours and is pretty strong. However, when things get out of hand, the innate system calls for help from the acquired immune system. This system can take days to mount a response, but the next time we encounter that pathogen, it won't make us get sick. In short, every day that we spend being healthy is all thanks to our immune system, so it definitely deserves our respect.
Okay, excuse me, that was faster than I could go through the innate and acquired immune system. The particles that signal the immune system to work are called cytokines. And cytokines are made by all of these different cell types. There are many different kinds of cytokines. Cytokines are signal proteins. And the one kind we really need to know about are called interleukins. Initially, they were felt to go just between white cells, but they communicate with all kinds of cells and all kinds of molecules. The question is, how do they do it and why is it important? Excuse me. Interleukins are created immediately upon contact. As soon as you touch the membrane, you make them, and they somehow signal messenger RNA to produce other interleukins. They work redundantly, and the symptoms they produce, we recognize as redness, swelling, tenderness, heat, or a strep throat, COVID. We recognize either symptoms or define it as a discrete illness. So the symptoms are coming from these interleukin particles. How do interleukins actually work? Okay, a little bit of cell biology, very briefly. There are membranes all through the body on every cell, but inside the cell, there are also membranes around the nucleus, the nucleolus, the different particles. There's an outer portion and an inside, and there's the wall of that membrane itself. The particle comes to the cell surface, and there's a receptor that greets it. Sometimes they can go right through, sometimes they hit the receptor. There are many different kinds of receptors, but we want to concentrate on one type today, the JAK-STAT system. Okay, the JAK-STAT system, you have a keyhole that the particle fits into. The particle is the interleukin, or the interleukin. It stimulates JAKs, which is released. The STAT particle is released, goes to the messenger RNA, which then creates a specific interleukin based upon the stimulated JAKs system. Okay, there are three parts. There's a receptor piece, there's the JAKs protein, and there's the STAT protein. JAK stands for Janus kinase protein, and STAT, not because it's immediate, but because it's a signal transducer and activator of transcription. STAT is much easier to say. It floats through to messenger RNA and makes a specific protein. Okay, are JAKs inhibitors important? Advertised on that news hour, we see Rinvoq all of the time. That's a Janus kinase inhibitor used in arthritis today. It's a dramatic anti-inflammatory agent that works by blocking the keyhole. Who is Janus? Anybody know?
God with looking in both directions.
Yeah, two-headed.
Roman mythology, Janus was the god of beginnings, gates, transitions, duality, doorways, and he's usually has two faces, a sad and a happy face. January is the beginning of the year and is named for Janus. So Janus kinase inhibitors, because they are the beginning of the system, I think is aptly named. Okay, just look at IL-2. There are lots and lots of different kinds of interleukins. We've identified about 50 of them. They're all similar, but they're different on the basis of where they were made, what their target organ is, and what their function is. IL-2 makes T cells grow and modulates the entire immune or inflammatory response to some extent. Let's look at our friend interleukin 17. It dramatically increases inflammation. It brings neutrophils to the site of inflammation, and it works in lots of illnesses that are not specifically infection. It causes inflammation in rheumatoid arthritis, allergy, asthma, psoriasis, Crohn's disease, all the illnesses that you have a hard time treating. So there's inflammation because the body recognizes something that is non-self, and it tries to kill that non-self. And these are the illnesses where IL-17 works. Now, IL-17 is not one protein. It's a related family of proteins, and that family of proteins is called isoforms. And there are at least 6 of them, A through F. A is made in T cells, and F is made specifically in T cells in the thymus. So if you combine IL-17A blockage and IL-17F blockage, you're principally blocking T cells that cause inflammation in different systems. Okay, now we can understand what this non-pronounceable Bimzelx actually does. He doesn't have a shirt on because you're trying to see that he no longer has his psoriasis, which was treated because of the ANF difference. By blocking interleukin 17A and 17F, we've blocked the interleukins that increase the inflammation of the disease process. So we haven't killed an organism, we haven't changed the underlying cause of the illness, but we've blocked the body's response to it. We blocked inflammation, and the patient goes on with his life. Okay, another concept, a disease or a multi-system disease. Rheumatoid arthritis is disease of the joints. You damage joints and you get rheumatoid arthritis. Well, if you look microscopically what part of the joint is inflamed. It's the membrane around the joint called the synovial membrane. You have membranes around the lungs, around the intestine, around the stomach, in the mouth, around the brain, in the eyes. And those membranes also become inflamed in rheumatoid arthritis. So rheumatoid arthritis is a disease involving many systems because membranes are involved all over the body. So you can call it a disease, or you can call it a multi-system disease. Lupus is one disease, but you have rash, joint pain, pericardial disease. So is it a disease or multi-system? Lupus is called a multi-system disease because of its profound manifestations all over the body. If you think about disease as the way to look at an illness, like a strep throat, you prove it with a positive strep culture and you treat with penicillin or erythromycin. Rheumatoid arthritis, we can do a blood test and have a rheumatoid factor and treat with one of the drugs that's advertised, Humira. It blocks a mediator called TNF-alpha, which is one of these immunologic responders. In Crohn's disease, you can define it with a barium enema, and Skyrizi, one of those newer drugs, blocks whatever the marker is. Systemic lupus, anti-DNA antibody. Wait a minute now, here we go again. You take DNA and your body is supposed to know what belongs to you. Well, our DNA is our DNA. Why do you respond and make anti-DNA antibodies? Let's assume that there's a virus going all through your body and you can't kill it, so it ends up living in different areas, including on the DNA molecule. That DNA is no longer native DNA. It's been modified by a small protein that the body recognizes as non-self and makes an anti-DNA antibody. Dr. Hargraves in 1948 was studying patients with lupus. Problem is, there was no way to really define what lupus was because it had kidney disease, joint disease, pericardial disease, rash, and he was busy. He took blood from a number of patients, put it in his jacket pocket, and continued seeing patients. And at the end of the day, he went to the laboratory and looked at the blood, and lo and behold, he saw something unusual. He saw a polymorphonuclear leukocyte that had phagocytized or engulfed DNA material that was abnormal. And this is called the LE-PrEP. This is the way you make the diagnosis of lupus in the old days. And what he had done differently than other physicians was he didn't look at the blood immediately. He incubated it at his body temperature for a couple of hours, enabling the phagocytes to work and phagocytize the abnormal DNA. So he made and defined anti-DNA antibodies. Treatment, there's no good treatment, but this is a disease approach. Let's look at the same illnesses with an inflammation-based approach, as a multi-system approach. Strep throat, you have a positive blood culture, but you have many interleukins that are elevated as well. We don't need to treat them because penicillin or erythromycin work so well. But in rheumatoid arthritis, if TNF-alpha Humira doesn't work well enough, we have elevation of interleukins 1 and 6, and Actemra, one of those advertised drugs, blocks specifically interleukin 1 and 6, and the membrane disease diffusely through the entire body recedes. Also in rheumatoid arthritis, we can block the JAK-STAT receptor with Rinvoq, one of those medicines. Crohn's disease, we can block interleukin 6 or 23 with Skyrizi. And our drug Bimzelx works for psoriatic arthritis, plaque psoriasis, because of elevated levels of IL-17A and 17F that are blocked specifically by this drug. In lupus, we haven't found a key yet that works because there's so many interleukins involved. So we try to modulate the system. Okay, prediction is very difficult, especially if it's about the future from Niels Bohr. I thought that was pretty good. So my prediction is inflammation-based treatment will become more common as well as more confusing. And just to show you the confusion, over the last couple of weeks, I didn't look a lot, but these are the drugs that block inflammation that were advertised. Here's Bimzel's blocking interleukin 17A and F. Actemra blocks interleukin 6. Here's a Janus STAT pathway blocker. So interleukin blocking in one way or other has become the state of the art. So the goals of our talk to review inflammation, the importance of aspirin, NSAIDs, and interleukins, a little bit about cell biology and mRNA signaling, messenger RNA signaling, the concept of interleukins, which are the worker bees of inflammation, and the relevance of inflammation today, direct-to-patient advertising. So the doctor monk makes a monastery call and looks in his throat at the novice monk. Ah, it's very inflamed. Why don't you take a vow of silence for a few days? So
Thank you very much.
Jerry. Very good.
oh,
All right, we have some
Thank you.
stuff in the, we have some stuff in the chat. Let's see what's going on there, and then we can take questions. All right, let's see. Okay, that's not that important.
Judy and Mike Alexander mentioned the prediction code is attributed to Yoga Berra, not Neil Bohr. I think Yoga Berra was after Neil Bohr. I found it in a science system, and Neil Bohr said it or something else. And Yogi Berra was obviously a scientist who read everything Neil Bohr wrote and knew about.
Well, you know what Yogi Berra says, when you find a fork in the road, take it.
You
Yeah,
might
right.
need it when you want to eat later, yeah.
A question from here too.
Yeah.
You got it.
Yep.
Yeah.
Let's see what we have here, and I think that's it. And they're talking about the talk. So we had a question from the room.
Yeah, can I ask one quick question? Interleukins are made by the body. They're made naturally. They come in a variety of forms, and they come at a variety of times, and different ones are made. What's their purpose for being there? In other words, what is positive about the interleukins that our bodies make?
Okay, there are ways of answering that which are teleological, which I won't get into. But the immune system is developed over millions of years, and you needed a signal mechanism to make the system work. The cell membrane blocks proteins non-specifically from getting inside. How do you tell messenger RNA to make an interleukin that will eventually make an antibody? You have to signal it in some way. The interleukins then are the travelers, the signalers that somehow get through that lock-and-key system into the cell to signal messenger RNA to work. So they are the critical, important component of the system. We're just learning about them after all these years. And if you block them specifically, you modify the balance of the interleukins. And we might learn over the next 40 to 50 years that the more we block one interleukin, the more others rise, and we might be defeating our own purposes. But they are the signal mechanism for the system.
But if you have interleukins, don't they have a positive effect on the body? In other words, they're not there just to cause inflammation, are they?
They have a positive effect as well. until a disease comes along. When a disease comes along, then you modify the system. They're yin-yang, that's positive and negative effects. You're right on.
Thanks.
All right, I'm gonna go left to right on my screen, so John Rudy.
I have a question about expiration dates. I have both aspirin and antihistamines in my cabinet. The antihistamines have an expiration date of 2008, but it appears that when I have an allergy attack and I take one, they seem to work. The aspirin has an expiration date of 2012, and that also appears to work. Any comments?
Sure.
Call the FDA.
If you follow the expiration dates completely, all of the pharmaceutical companies will thank you profoundly. The rationale is that there are two things that happen. First of all, you have the drug itself and you have the excipient, the filler that holds the drug together. They both deteriorate over a period of time. When you open up a pill bottle, if it smells like formaldehyde, it has deteriorated, throw it away. The excipient is bad or the drug is bad. Many of the drugs will not deteriorate over 20, 30, 40, 50 years, but the excipient will, and it will modify it. Other drugs, they will lose their efficacy over a period of time. Tetracycline, as an example, modifies over a period of time and becomes severely kidney toxic. So if you use out-of-date tetracycline, you can get some significant kidney problems. So that's one drug I would never use out of date. Aspirin, you're losing some of the efficacy of the drug, but not that much. So you first open the bottle. If it smells good, probably use it, but just be cautious with antibiotics.
Thank you.
Jeremy, is it also that the FDA only tests for about a year, so that's all they can actually say that the drug is good for? There's some involvement in government testing that gives you the 1 year date on?
Well, the Food and Drug Administration relies on the drug company data, and it reviews it and it studies and modifies its own recommendations based upon what the drug company and the manufacturer puts out. The manufacturer is required to do serial surveillance over a long time and report all the ill effects to FDA. So that's where the data comes from. It's not that the FDA does its own work. It doesn't.
Right, but the 1 year is an economic thing, is that drug companies, before they put the drug on the market, don't really test, the efficacy after a year or worry about it because it's just too expensive to do that and hold the drug off the market until they understand that after 10 years, it doesn't turn into slime.
Well, that's an interesting question. The drug company gets a patent on a drug when it buys the chemical. It then manufactures it, modifies it, studies it, does clinical testing, and finally, after 7 or 8 or 9 years, gets it approved and puts it on the market. It then has its patent left only for 7 or 8 years. Now, it wants to keep that patent to keep making money. So it's patented, pick a drug, Rinvoq, for rheumatoid arthritis. But while it was studying rheumatoid arthritis, it started studying another indication, psoriatic arthritis. And all of a sudden, they now have patent approval for psoriatic arthritis and can extend their patent because of that. So it's a very difficult game. After their 17-year patent runs out, they modify their indication and can keep the patent for much longer. I'll tell you a funny story. Going back to the drug that we mentioned, peripherally colchicine. Food and Drug Administration made a ruling a number of years ago that the only drugs that should be in the pharmacopoeia in the United States are those that have been proved to be safe and effective. Those are the two words, safe and effective. Hey, Colchicine has been in the pharmacopoeia since before it was studied. It came from Greek literature. It was used homeopathically in Roman times. No company in the United States or in the world ever studied it. So an enterprising company came along and decided to purify it a little tiny bit more. They changed the name from colchicine to Colchris, showed double-blind controlled studies that it worked perfectly, put it on the market with a patent, and then petitioned the drug company to take old-fashioned colchicine off the market because it had not been proved to be safe and efficacious. The result was colchicine went from a penny a pill to 50 cents a pill overnight.
Wonderful, wonderful. Carl?
Yes, so there are some infections that seem to occasionally cause really long-term effects, and where there doesn't seem to be evidence that the infectious agent is still around, although maybe it is in some hidden form. So I'm certainly thinking long COVID. I'm also thinking of Lyme disease. Are these things most likely due to the body's immune system going haywire?
Well, we used to talk about autoimmunity. Well, we're never immune to ourselves. Our body doesn't make antibodies meaninglessly. It responds specifically to an altered protein. The same thing obtains with chronic Lyme disease, whatever that is, or chronic COVID. The body is responding to something, making inflammatory molecules. So the problem is we can do a throat culture and look for strep. We cannot analyze 50 different interleukins and see which ones are elevated or not. That's a research laboratory's function, and no laboratory is doing that. So at this point, no one knows which interleukins are elevated across the board in Lyme disease or COVID or other illnesses that seem to be prolonged and not going away. Prediction. I suspect we will sometime find that a partial protein of the organism is existing somewhere in the body on RNA, messenger RNA, and our body is responding to it appropriately, causing inflammation. The treatment will eventually be geared to blocking another signal protein, another cytokine.
Jerry, just to clarify what you said, you called it chronic COVID and chronic Lyme disease. If we really don't know what's causing the disease, how do we classify it as related to COVID or related to what we know as Lyme disease without understanding the rest of it?
Well, we don't know. I mean, it's a perfectly fair question. Somebody has Lyme disease, you treat the Lyme disease and their symptoms keep on going. Are the ongoing symptoms related to Lyme disease or not? There's a whole book in medicine about diseases of the different ages, which are unexplained. And we used to talk about fibromyalgia, fibrositis. Well, I mean, that's an inflammation seemingly that people have, but you can't measure anything abnormal in the blood, except no one ever measured interleukin levels. So now that we have the ability to start measuring different mediators, we may find that these people have something that we haven't been able to define before. So the reason we call it chronic Lyme disease is it seems to be chronic after Lyme. The reason we call it post-resurgent polio is the symptoms worsen 10, 20, 30 years after polio. And I'll give you a perfectly legitimate example of this. Everybody, 99% of people, has had chickenpox. What illness do you get 10, 20, 30, 40, 50 years after recovering from your chickenpox?
Shingles.
Shingles.
Shingles, that's right. Shingles is recrudescent chickenpox because the chickenpox virus has lived in our body somewheres, in nerve endings and nerve roots during that entire period of time. And it didn't make its presence known. But suppose it had been a nuisance over all that time, causing numbness and tingling in the nerve roots. We would have done something long ago to try to fix it. So viral particles live with us in the genome long term and will cause symptoms.
Howie, good to see you. Question.
Yeah, how come the Romans didn't get much rheumatoid arthritis?
Well, there are many illnesses that seem to be newer than older. To give you an uncomfortable example, COVID is a new form which is much more virulent of an old virus. And the newer form causes disease to an extent that we didn't see before. We had genetic diseases like psoriatic arthritis that we can see in skeletal remains. We have osteoarthritis we can see in skeletal remains. But maybe some other talk, we can talk about different kinds of arthritis and how you can tell them apart. There's a very real difference between psoriatic arthritis, rheumatoid arthritis, osteoarthritis, and the skeletal remains show the differences. We don't see rheumatoid arthritis in very old specimens. We see it in newer specimens. So it does seem to be a mutant form that happened more recently. By more recently, we're talking about 500 years, 1,000 years, something like that. The immune system makes different types of antibodies. There are basically 5 of them: IgG, IgA, IgM, IgD, IgE. They work in different areas. IgG is a chronic antibody that we kind of keep in our bloodstream all the time. IgM is an acute phase reactant that occurs immediately after an immunologic response. IgA is an allergy response, principally in the mucosa of the nose and the GI tract. IgE is diffuse allergies like hay fever, ragweed, different kinds of pollens. So first of all, there are many different kinds of immune responses. The timing is different on every one. And I can't really define why one thing happens and one doesn't. But the best example is people who get anaphylaxis from me. I get anaphylaxis from shrimp and shellfish. Well, it took 20 exposures with a hive once in a while until I had my first anaphylactic reaction. Why were some reactions more mild until I had a severe reaction? I have not been able to find out. So in answer to your questions, you've manifest allergic reactions long term. You've shown that you have the allergic diathesis. Its expression is different based upon the exposure.
So the timing of the 2 years, because my other symptoms sort of died down initially, so
Yeah.
I was assuming that probably the kind of spectrum of different types of pollens that are floating around was different between Central Texas and New England. And then again, never having been exposed to this other thing. Now I come back up here, after 10 years in Austin, Texas, and I have more sensitivity to pollens that I didn't have before. So that's the second part of the question.
That's true. Your body remembers the initial allergy and responds to it again. And you modify it to some extent because your body learns how to modify it and protect yourself to some extent. It varies over time, yes.
Can you unlearn it?
Ed, you got to give other people a chance.
So I have a question
Yeah,
about.
so that's a relevant part of the question. Can you unlearn these things?
What do you mean by run with it?
No, unlearn is what he wants. By the way, Jerry, also
And
make
I
sure
learn
you
new
get-
ones. Can I unlearn some of the ones that no longer are relevant?
I see. No, you can't. You cannot get rid of those memory cells that are in your body, part of the acquired immune system, and those memory cells will be there. Now, what some people do is they take an antihistamine long-term every day, every night. The problem with that is the effect of the antihistamine is drying, makes your eyes irritated, and makes you more forgetful, makes you sleep more. So it's not a great idea. The better thing to do is wait for the symptoms to occur and ablate them when they occur with treatment seasonally.
Jerry, don't forget to get Ted's billing address. Okay. We had a question in the LCC here.
Yeah, so I have a question. This is mostly about blood and what's in blood, but from what I understand, in the large intestine, the diversity of your microbiome trains your system about how to respond to things, and it's important to keep that naturally diverse, and that really can reduce inflammation from a lot of sources. Could you get into that?
That's a whole lecture in itself, but very briefly stated, the microbiome is critically important, and every time we take an antibiotic, we kill off certain portions of it and other bacteria grow. So for instance, when you take a penicillin, you get rid of all of the gram-positive organisms. Gram-positive means those organisms that stain with a particular stain called a gram stain in the laboratory that is positive, a purple stain. Those are gram-positive organisms. Those are mostly organisms like staph and strep, and they live ubiquitously in our body, on our skin. They're part of our microbiome. When you kill them off, you grow fungus. You grow gram-negative organisms, other organisms in their stead. What do the organisms do for us? They metabolize foods in the GI tract for us, but they also make these leukotrienes. They also make, interleukins. The interleukins that we've talked about are made in part in these organisms. They make signaling mechanisms that interact with the rest of the body. Microbiome is critical. And again, we're going to learn more about it over the next 20, 30 years. It's a relatively new field in the treatment of different illnesses. Right on.
Thank you.
I have a question.
Carl, I'm going to do Bob, and then we have a question at the LCC, and I'll come back to you if you don't mind.
Okay. I just wanted to briefly mention that some people can be treated to be desensitized to allergies that suddenly show up that they never had before. I got one to a yellow jacket sting, and I am under treatment for it. It is an immunological type of treatment.
Hard to explain why. I'll give you a quick anecdote. My sister-in-law, who has been getting allergy shots for years, came to me one day and said, my doctor told me I have rheumatoid arthritis, treat my rheumatoid arthritis. She didn't have rheumatoid arthritis, she had serum sickness from the allergy shot she was getting. The antigen was the pollen. The antibody was the injection she was getting. And the pollen levels were so high that the antigen and antibody in her bloodstream were reacting, floating through her bloodstream, settling in joints, causing what looked like rheumatoid arthritis. Her treatment was to stop the allergy shots.
Yes, I've been told to watch for side effects as well.
That's right. That's exactly right.
Go ahead. Who had the question?
Okay. Yeah, glaucoma is a kind of eye arthritis.
Glaucoma.
Yeah.
Yeah.
Is it a kind of eye arthritis for eye?
I'm sorry, please repeat the question for me, Ted.
He wants to know if glaucoma is a kind of arthritis related to the eye, correct?
Yes.
Glaucoma is not an infection related to the eye. Glaucoma, if I'm not mistaken, there are two different mechanisms for it. There's a closed angle and an open angle glaucoma. And both these are related to the influx and efflux of fluid from the chambers of the eye related to a duct that is wider or narrower in some people. And glaucoma treatment is geared to altering the pressure in the eye by increasing or decreasing the amount of fluid in the eye. That is not principally an inflammatory illness, no.
Thank you.
Carl, go ahead.
Yes, so when I was in my 20s and 30s, I occasionally got really severe sinus headaches, and I never left the house without carrying an antihistamine with me, so that when I got the beginnings of the symptom, I would take it right away. And then somehow it went away. Never had it again since my late 30s. How does something like that happen?
You got married.
Okay.
Yeah, lucky.
Children get many ear infections. And as they get older, they get fewer and fewer ear infections. And over a period of time, you outgrow them. Why do you outgrow them? It turns out that the anatomy in the child is that the eustachian tube is lower and angled differently. The result is fluid will collect there and increase the risk of the infections. The sinuses, by analogy, grow and mature over a period of time. And if you take an X-ray of sinuses, looking at the frontal sinuses, which you see very easily in young people, they're underdeveloped. The sinuses develop through a lifetime. And the bigger the sinuses are, the fewer sinus infections you have, we believe. So I think as they develop over a period of time and mature, you get better drainage. The ethmoid air cells, for instance, have all kinds of lining membranes in them. But once they enlarge in size, you decrease the ability to hold fluid in them. So I believe that the answer is you outgrew it because you developed more sinuses over a period of time, which we all do.
Thanks.
Here you go.
My father had all these strange theories about things. One of his weird theories was that the reason that women had more incidence of autoimmune type diseases was because there were two X chromosomes, so there were two different variations of some of the proteins that were being produced, and they interacted with each other. Does that make any sense at all?
Well, the first part of it makes a lot of sense. There clearly is more lupus and in women than in men. And there clearly is more rheumatoid arthritis in women than in men. We don't believe it has anything to do with the X's or Y's. For a period of time, one wondered if it was related to estrogen production itself. It turns out that postmenopausal women still have more development of lupus and rheumatoid arthritis than men. So the answer is unclear. So the first part of the surmise is correct. The second part, unknown. I can't give you an answer for why it happens, but the observation is correct.
Adding on to that, there was a paper, I think it was a week ago in Science magazine about exactly on this topic. And they were showing, without going into what the mechanism is there, they were showing you that there definitely is a relationship, and it's on the X chromosome. And it's what's going on basically is there's a blockage of that X chromosome by another messenger RNA that's being made. They don't know what is going on there, but at least there's now getting more and more data on the genetic aspect of those two diseases, particularly related to the X chromosome.
I'd love to see that article if you could send me a reference.
Yeah. Okay,
Please.
I'll do it. Try to do it today. Yeah, thanks, Jerry.
Jerry, it's getting late, and I have one final question, perhaps. During your talk, you talked about messenger RNA and how things get changed on that. Can you relate what you talked about to the development of the COVID vaccines, the mRNA COVID vaccines, and what goes on there? Is it a short answer? If it's a long answer, thanks very much anyway.
It's a long answer, but very briefly, vaccines never used to be related to messenger RNA. They used to be made without any awareness of the immune system. We just knew you could make an antibody. You made it in an animal like horse serum for tetanus, or in humans, or in the laboratory. With the new messenger RNA technology, we can stimulate through any one of those locks and keys the development of any protein we want specifically and make it. And the messenger RNA vaccines respond because we tell them to respond and making anti-COVID antibodies. So that's what it is. That's true.
Fair enough. Good.
Long talk.
Good.
Well,
any other questions? Anything else going on?
well,
No.
I wouldn't
Let
feel.
me ask one more expiration question, since I was just reminded about the COVID point that Peter brought up. Is the reason that those expiration dates are so short because there just hasn't been much time to test to see whether they're good for 5 years?
Yes, I think that's perfectly valid. I think that we will find over a period of time variation in those dates. One of the companies makes sure that you keep the COVID vaccine frozen minus, I can't remember how many degrees, before thawing it and using it. And if you thaw it out, it's not going to be worth anything. So it also depends on the characteristics of the protein and how it's put together.
So is it likely that even those that are beyond the expiration date are probably still good for a while?
Yes.
Many of us have tons of this stuff sitting in our closets.
Yeah. Well, the COVID testing kits themselves last much longer, and they have already had their lifetime lengthened by FDA. Some of them. It depends upon the manufacturer too.
And you could look on the internet for expiration dates.
I already have.
Well, for other people who haven't, you can put in the lot number of the test that you had, and you can find out what the current expiration date is for any test that you have that may be old, because they do update them from time to time.
They read what the FDA puts out, and they put out their data, and they just do it. The problem is, if you look at the physician's desk reference and pick any drug you want to, you will find any side effect you want from any drug. You will find my hair turns gray after I use it for a month, green eyes, yellow hands, arms falling off. Any side effect can be defined on the basis of any drug. So how do you test these things in double-blind controlled studies? What you do is you look for major side effects, worry about them, and the other ones you do a statistical analysis, and you just say, this occurs in less than 1% of the population, and you leave it at that. The Food and Drug Administration accepts that kind of an analysis.
Thank you, Jerry. Thank you so much for a wonderful presentation. We're all a lot smarter, and it's going to help. You're welcome to come back and do part 2 anytime you want.
Thank you.